Hello and welcome to the Support for Doctors Returning to Work in Pandemic evening webinar. We are very pleased to welcome Dr. Krishna Chintapalli as our speaker this evening. He is a neurology consultant at Frimley Health NHS Foundation Trust. The first session tonight he will speak about is neurological emergencies, and then we will have a short break for about 15 minutes and return again for the second session on seizures and status around 8 p.m. Thank you so much for joining us this evening, Dr. Chintapalli.
Hi, no problem. Thanks to all the participants for joining us this evening. Hi, I'm not sure. Am I live now?
Yes, that sounds good.
Perfect. So, hi everyone. So my name is Krishna Chintapalli, and we'll talk about neurological emergencies first. Just to begin conflicts of interest, I gave 2 talks on sudden death in epilepsy last year for pharmaceutical companies. They're not relevant to this. I work at Wexham Park Hospital as a consultant neurologist, as you've heard, and also at the National Hospital for Neurology in Queen Square in London, which hasn't changed all that much from that picture on the right. Most of you won't be able to see me on video tonight, so that was me after my shift last night. Yeah, that's all true. And in terms of neurological emergencies, I think there's 3 main topics that I want to cover this evening. And seizures we're going to do separately in the second talk. So in this talk, I chose headache and weakness as the neurological emergencies to discuss. And the reason for that is they're the most common symptoms that present to emergency departments in terms of neurology, acute neurology. And this is one study of many. This was a few years ago at a center in America. And you can see the top 3 symptoms there: weakness, seizure, and headache. Together almost a half of anyone presenting with neurological symptoms. And also there's a few serious conditions to know about within these categories. So we'll start off with headache. Headaches can be divided into primary and secondary before we talk about anything further. So primary headaches are those without any damage to the underlying brain or to the head and neck. They're relatively easy to manage, and they're quite pleasant to manage. Secondary headaches, on the other hand, are quite complicated. They're quite messy and unpleasant to manage. They're due to damage to structures, and it could be a range of structures in the brain itself or the head and neck. Thankfully, secondary headaches are uncommon. They probably occur in less than 10% of patients presenting to the emergency department, and this includes all of the emergencies in terms of headaches. So I think your job in acute medicine and my job as an acute neurologist is to exclude secondary headache. That's our main aim. Actually diagnosing the headache comes secondary to that. And of course, if we can make a diagnosis of a primary headache, then it's best to try and treat it, and also it's even better if there's a long-term follow-up plan. But the emphasis should really be on excluding those dangerous causes of headache. Even though they're unlikely, some of them can be life-threatening. So this is from an article a review article that we wrote for Clinical Medicine a couple of years ago, and the references at the bottom. These are some of the major causes, and I'll talk about a few of them. Some of these are quite rare, but we'll start with probably one of the commonest. Just before then, actually, I forgot to mention about red flags. So there are a number of red flags for headaches, and I find it easiest to divide these by the type of condition that you're trying to rule out. So if we look at 3 of them, and these are 3 I'll talk about in a second as well. Raised intracranial pressure presents typically with nausea, vomiting. It can cause pressure on the optic nerve, which leads to papilledema and blurred vision. And there's also this the evidence of the raised pressure as a postural symptom. So people find their headache gets worse when they lie down and gets better when they stand up. Often that presents as a morning headache. After a night of lying down, the headache tends to be more severe. And then subarachnoid hemorrhage, which can also present as with a raised intracranial pressure type headache, typically because of the nature of the subarachnoid hemorrhage, presents in a very classical sudden onset headache that we call a thunderclap headache. Sometimes that can occur during instances when your blood pressure is raised. Typically, that's exertion. And lastly, meningitis. So there's a couple of features that meningitis has, apart from fever, of course, that makes it slightly different. And that includes photophobia and neck stiffness because of the inflammation of the meninges. On examination, you'll be pleased to know there's not actually much that we think is important in a neurological examination for someone with acute headache. The important things are really to do with the eyes. So looking for a Horner syndrome, I'll come back to that. Photophobia, as I mentioned already, is a symptom of meningism. And papilledema. Neck stiffness, temporal artery pulses are also useful to do. Temporal artery pulses for giant cell arteritis, of course, especially in people over the age of 50. So you'll be pleased to know no tendon hammer is needed for the examination of someone with an acute headache. But it is very important to find an ophthalmoscope and have a look at the back of the eyes. This is a mnemonic that's become quite widespread called SNOOP, which may help you to remember the red flags for headaches. So S is for systemic disorders and signs. So this can include fever, immunosuppression, cancer, for example. N is for neurological symptoms, focal neurological symptoms. So for example, weakness or blurred vision. O, both those are for onset. So one is onset in someone over 50 and a new headache, and the other O is for thunderclap headache, specifically in relation to suspecting subarachnoid hemorrhage. The P, there's actually about 4 P's in there, so you can see this mnemonic is a bit forced. It's not probably easy to derive the words from the actual letters, but I think is the easiest one there is. So if Snoop helps you, then so be it. Meningitis, sorry, I won't pause on that slide for too long. I appreciate many people are probably having dinner. Meningitis, there's a few things I want to say. So I'll start with these signs. So Koenig sign, Brudzinski sign. I mean, I see a lot of people document these in the notes. And Koenig sign is shown there with the instructions. So essentially you're bending the leg and then you're straightening out at the knee. And Brudzinski's is just bending the neck forwards when the patient's lying supine in both of these. The principle behind both of these is that you're trying to stretch the meninges. And if the meninges are inflamed, as they are in meningitis, then it's going to cause pain, and the patient will adopt a posture that will minimize the pain. In the Brudzinski sign, that's flexing the knees. So these signs, I suppose they're historical and they've been around for a long time, so everyone seems to know about them. But I have to point out that the sensitivity is actually very low. So these are signs that are only positive in people with very severe meningitis. And actually the kind of people who would have positive Koenigs and Brudzinskis are probably those people who can't move their neck in any way, really, because of how severe their meningitis is. What I think is much more useful in terms of the examination is something called jolt accentuation. It's only been described recently, but it's the same principle of trying to see if the meninges are tender, but it's much easier to do. And essentially all you're doing, as in the diagram there, is just rotating the head yourself with a hand on either side of the face to the left and the right quickly, and not that large in amplitude. It's only a few degrees to left and right. And you just ask the patient if the pain gets worse. And it's a yes in meningitis typically. As you can see, the sensitivity is a lot higher. So this is positive in many people with meningitis, whereas Koenigs and Brudzinskis aren't. The advantage that they have, of course, because they happen in severe meningitis, is that they're very specific for meningitis. And you can see on the diagram on the right, obviously this has gone international, so it must be a good sign. I'll just talk briefly about some of the other signs and symptoms with meningitis. So this is from a New England Journal of Medicine article, and it's these 4 symptoms that I wanted to just mention. So fever, mild confusion, so GCS of 14 or less, headache, sorry, it's meant to be 13 or less, so less than 14, headache and neck stiffness. If you have 2 of these 4 symptoms, then the sensitivity of picking up meningitis is 95%. So what that means is if someone has a headache, but they don't have neck stiffness, confusion, or fever, it's very unlikely for them to have meningitis. So it's actually quite good as a way of excluding meningitis as a potential consideration. In terms of the diagnostic pathway for meningitis, after the history examination and bedside observations, including temperature, there's only really 2 tests that you need to do. So blood cultures as soon as possible, and lumbar puncture as soon as possible. The guidelines, the UK guidelines from a couple of years ago, say it should be done within 1 hour of arrival. I suspect many centres are nowhere near that, but that's the aim. And then antibiotics as soon as possible, of course, but that's part of the treatment side. In terms of trying to get to that 1 hour, guidelines have increasingly specified when a CT scan is needed. And the answer really is most of the time, you don't need to do a CT brain scan before the lumbar puncture in someone with suspected meningitis. And actually, you shouldn't do that because that adds delay to the lumbar puncture. And you may think, well, do we need a lumbar puncture early and getting a diagnosis for the organism? Actually, it has big implications in terms of the treatment efficacy and also complications. So CT scan in this guideline, the UK guidelines, there's only a few reasons when you should do a CT scan, and that's for seizures, focal neurological symptoms, altered GCS, papilledema, or someone who's immunosuppressed. So there's an acronym there, SNAPPY, which might be a bit easier than SNOOP. One other thing about lumbar punctures, so increasingly there are more patients on anticoagulation, and these are some of the various antiplatelets and anticoagulants in use. The guidelines also specify when you can do a lumbar puncture in relation to these. So so you can see here, so prophylactic low molecular heparin 12 hours and then 24 hours after the last dose for therapeutic heparin. Warfarin, it's ideally stopped 5 days before, so it's not that helpful in acute meningitis, and the INR should be below 1.4. DOACs are, of course, quite new. We have got antidotes, some of them, so reverse when possible. Otherwise, it depends on the individual agent for these, and usually it's between 24 to 48 hours. Aspirin is not a contraindication. Clopidogrel, it may surprise you, is, and it's 7 days. Urgently, it could be, a lumbar puncture could be done with a platelet transfusion. But generally, we tend to avoid it in neurology if someone's on clopidogrel unless they've stopped it. And then treatment pathway. Again, not much has changed with the treatment of acute meningitis, acute bacterial meningitis. The treatment really comprises IV ceftriaxone 2 grams twice a day. If they're penicillin allergic, there's an alternative, so IV chloramphenicol. IV dexamethasone is given as well, and that wasn't the case about 10, 15 years ago. But the reason for that is to prevent the complications of one particular type of meningitis, which is pneumococcal meningitis in adults, which frequently leads to complications from an exaggerated inflammatory response. So, for example, deafness is quite common after pneumococcal meningitis, especially with delayed treatment. And if someone is aged over 60 years, then IV amoxicillin to cover for listeria. And again, there's an alternative if the patient is penicillin allergic. No one's really studied the optimal treatment duration, but we think probably at least 5 days is sufficient. And that's all I'm going to say about meningitis. So I'm going to move on to another pathology, and this is subarachnoid hemorrhage. Subarachnoid hemorrhage, of course, is just one of many types of bleeds in the brain. If we look at the others, so epidural hematoma, typically it's a severe trauma. It's an arterial bleed. There may be a lucid interval, inverted commas, of a few hours probably before there's rapid deterioration. And then subdural hematoma, quite different. Those are bridging veins, typically in the elderly who have longer bridging veins that are more susceptible to be torn. It can be minor trauma, such that the patient may not even remember it. And this can take days to present. And then lastly, intracerebral hemorrhage, which is essentially a type of stroke. And I'll talk about that later on. So coming back to subarachnoid hemorrhage, it's a bit like meningitis, and there are some symptoms which are the same. And this is because there's blood irritating the CSF and the meninges instead of pus in bacterial meningitis. And you get neck stiffness and photophobia in both of these sometimes. But the hallmark of a subarachnoid hemorrhage is, of course, the thunderclap headache. And what do we mean by a thunderclap headache? I'd like to emphasize that a thunderclap headache is one that reaches maximum intensity within seconds. The definition says within 60 seconds, but in practice, most of these are at maximum severity right at onset or within the first 10-15 seconds. They usually last, well, they have to last over an hour in the definition, but most of them will last over 24 hours. Most thunderclap headaches are not due to subarachnoid hemorrhage. Probably about 90% of them are benign or have other causes. But of all of the causes of a thunderclap headache, subarachnoid hemorrhage is the most dangerous. So always suspect it in someone with thunderclap presentation. I think a lot of people don't really clarify the maximum intensity at onset, and that can be tricky to do. I think it's worth just asking the patient a very direct question, or a few direct questions, just exactly when the headache was at its maximum, whether it was at its maximum right at the beginning, or did it get worse, after 10 minutes or 30 minutes, because it makes a difference. And if it's not a thunderclap headache, much less likely to be a subarachnoid hemorrhage. So in terms of the diagnostic process, so for a subarachnoid hemorrhage, a CT brain scan should be done as soon as possible after the bleed. It's about over 97% sensitive at 6 hours, according to some of the evidence. But this is in tertiary centers with a neuroradiologist looking at them. When we look at real life data, let's say in the average district general hospital, actually the sensitivity is probably more like 80%. So CT is by no means sufficient to rule out a subarachnoid hemorrhage if you're suspecting one. And there's been a lot of debate about whether people are obliged to do a lumbar puncture. And the answer for now is yes. So if you suspect a subarachnoid hemorrhage and a CT scan, even early on, is negative, all the guidelines currently still say you should proceed to a lumbar puncture. And that's because a lumbar puncture essentially is almost or very close to 100% sensitive. The difference is a CT brain scan should be done as soon as possible. A lumbar puncture, don't do it too soon. It should be done after 12 hours at the earliest, because you want those blood products, bilirubin, to be present, and it takes time to degrade the blood in the CSF. Another caveat about a lumbar puncture is it's often best to have someone experienced do the lumbar puncture in these patients. It's not helpful when someone not experienced has a go, fails, or at least thinks they failed, but they may have introduced blood into the CSF, and then someone tries later on, because by introducing blood into CSF, of course, you're going to have positive bilirubin if someone does a subsequent lumbar puncture afterwards. But a lumbar puncture can be useful up to 2 weeks, and even at 3 weeks is probably 70% sensitive in picking up a subarachnoid hemorrhage. And essentially the point of both of these is that you're looking for blood in the subarachnoid space. Now, when you find that blood, you then go on to the next step, which is to find the source of the blood. And this is why it's very important to recognize these, because most subarachnoid hemorrhages occur because of a burst aneurysm. These aneurysms are usually in the base of the brain, and if they've bled once, there's a high chance that they're going to bleed again. And if they bleed, of all aneurysm bleeds, probably about a third lead to someone dying, a third lead to severe neurological deficits, and a third will make full recovery. So there's a high morbidity and mortality associated with aneurysms. So the management, if apart from looking for the aneurysm, is really to contact neurosurgery, because they need to treat that aneurysm. Increasingly, it's done by neuroradiology, but essentially you need to contact a neurosurgical center to decide on the best treatment. Secondly, the neurosurgeons will advise on this, but the second aspect is to avoid vasospasm, and this is when other blood vessels go into spasm and constrict, which can often cause severe deficits just as much as the initial bleed. So if the vessels go into spasm, essentially it's like having a stroke. The only medicine that seems to reduce the risk of this is nimodipine, and that's given at a high dose for at least 2 or 3 weeks. So very briefly, just talking about other headache types. So hopefully most of you will get the diagnosis here. So this is someone who has a left mild ptosis along with constriction of the pupil on that side. So this is a classic Horner syndrome. The relevance of this is that a painful Horner syndrome should always make you think of carotid artery dissection, ipsilateral to the Horner syndrome usually. And carotid artery dissection, this can happen in anyone of any age. It can happen with trauma, especially susceptible in those with connective tissue disorders, like Marfan syndrome. And it can present with, sometimes with neck pain on the same side as the dissection, sometimes just with a diffuse headache. So it's worth having a low threshold to suspect this. Sometimes it can present as a thunderclap headache as well. Apart from the Horner syndrome, some patients may have stroke symptoms as well. And then moving on to another type of headache. So this is a graphical illustration of something called the Monro-Kelly doctrine, a sort of neurosurgical concept. It's actually very simple. What it means is the skull is a box, and like a box, it's got limited volume. So if something enters the box, something else has to leave. And you've got these various constituents. You've got the veins, the arteries, the brain, and you've got CSF there. If you've got a mass that grows there, something has to give way. So typically that's CSF, venous blood. And then after that, the pressure inside the skull or box rapidly rises. And when you have, I'll come on to that in a second, about raised intracranial pressure. When you get raised intracranial pressure, you'll get effects on the back of the eye. But just to point out one of the stats. So in terms of new headaches, and we see this more in neurology clinics than you probably will in acute medicine, but patients are very worried, and sometimes GPs as well, that the headache could be due to a brain tumor. The statistic is really that 0.08% of all new headaches are due to brain tumors. So very, very unlikely. And most brain tumors will present with other symptoms. So the converse statistic is that only 2% of brain tumors will present with just a headache. So hopefully that puts things into perspective in terms of headache and brain tumors. So coming back to papilledema. So with raised intracranial pressure, the back of the eye, I'll show you in this diagram here, hopefully you can see the cursor. This blue bit is CSF. So the back of the eye is essentially in contact with the CSF space. So if you have raised intracranial pressure, the CSF is pushing on the back of the eye at the optic disc. And this is a cross-section of the optic disc, and it sort of bulges it forwards. And that's really what we see when we're looking at the back of the eye. So just be aware that it's a 3D sort of bulge forward that you're seeing when you're looking at papilledema on the back of the eye. And papilledema, so there's 5 different grades, and this is from the mildest to the most severe. I appreciate this looks like the most severe, and this is sort of chronic papilledema, where you can see the vessels have disappeared completely. So this is the Frisson grading system. I appreciate it can be quite difficult. So papilledema, essentially the clearest finding is the blurring of the optic disc, the margin of the optic disc. So for example, it's clear there and it gets blurred, increasingly blurred. But you can also see that 3D effect, like it looks like a bump, doesn't it? Coming out is more and more obvious. But then, some of you may be thinking, well, I can't even spot a white dress from a blue dress, so how am I going to spot the blurred margin? Well, there is another way, and this is probably an easier way. It does require fundoscopy still. Sorry to disappoint you, but it's easier because you're just looking for movements. And these are called spontaneous venous pulsations. So if you look at the blood vessels, and typically the larger blood vessels that you see in the retina will be veins, you're looking for pulsations of the veins. And I'll just show you that on this clip. Apologies for the music in advance. It's from the internet. So hopefully you could see the pulsations there. If you haven't, I'd suggest looking here, and it's quite clear there. So I'll stop there. So what is the relevance of that? Well, if you can see spontaneous venous pulsations, and up to 80% of the general population will have them, that effectively excludes raised intracranial pressure. So if the CSF pressure is raised, you won't see that pulsation anymore. And that can be quite useful to spot if you're not sure whether the disc margins are blurred or not. Okay, moving on from that track. So the second main symptom for the talk is weakness. How am I doing? So I think we're on track in terms of time. So weakness can be anywhere in the nervous system. So this is a representation of the nervous system, and we're looking at typical motor nerve pathway. So you've got the upper motor neuron that starts in the motor cortex, comes all the way down through the internal capsule, through the brainstem, and then crosses over and then goes down the spinal cord. So that's all one motor neuron. It then synapses at the level of the spinal cord where it's going to exit, and then you've got the lower motor neuron that comes out at that level, which would be one of the spinal levels. So we call them myotomes, ranging from C1, C2, all the way down to L5, S1, etc. So the low motor neuron will come out in one of those neural foramina out of the spine, and then it'll go and innervate the relevant muscle. So you've got those two nerves, neurons, and essentially whatever is causing the weakness has to be pathology affecting either of those neurons or the neuromuscular junction or the muscle. And these are some of the conditions that I think can present acutely. So I'll talk briefly about each of these. Now, bear in mind, I would say each of those can be a talk by itself. So we are going to rush through some of these, but hopefully you'll have a sort of overview of the conditions. Stroke, I'm sure you all know about FAST and recognizing stroke. A couple more letters have been added in, so loss of balance, loss of vision as well, which are also important, of course, in certain types of stroke. I suppose the most important feature of stroke is sudden onset. And there's not many things in neurology that give you sudden onset of neurological deficits. So anyone who has a sudden onset, you should always suspect a stroke as the cause. And strokes are of two types. So you've got ischemic and hemorrhagic types. Ischemic being the cause in about 75% of strokes, and hemorrhagic in the remainder. So in the ischemic strokes, this is helpful. So it's not some weird tribal artifact. It's actually this. So yeah, it makes it more disturbing that someone would have that as jewelry. But this is the circle of Willis, of course. The relevance of this is any clot in an ischemic stroke that's caused the damage must have passed through these vessels, and a stroke is due to occlusion of one of these vessels or their branches. So knowing a bit of anatomy can help in terms of diagnosing what type of stroke syndrome someone has when they present. So in terms of symptoms, so in terms of bleeds, firstly, patients will typically have severe hypertension that's caused the bleed spontaneously. Because the bleed is essentially blood occupying space, as we saw in the Monroe-Kelly doctrine, they may have symptoms of raised intracranial pressure. Blood is also very irritant to the cerebral cortex, so they are more likely to have seizures. Most of the people with stroke who have seizures tend to be those with hemorrhagic strokes. And then the remainder of strokes are the infarcts, and these are the ones that might fit into a vascular territory. So if you have an anterior cerebral artery stroke, for example, typically there's contralateral leg weakness. And if you have a posterior cerebral artery, typically it's hemianopia, and possibly some brainstem or cerebellar signs. If you have a middle cerebral artery stroke, then that's the typical stroke with contralateral weakness, especially affecting the face and the arm. And that's to do with the homunculus, the motor homunculus. But if you can't remember that from your time in medical school anatomy, then don't worry about it. And of course, the other thing, say, in most people, even those who are left-handed, is probably 50-50 or 60-40. In most people, language will be in the left hemisphere. So a left MCA stroke typically will lead to aphasia. Whereas a right MCA stroke doesn't affect language in most people, but can lead to neglect or inattention. So people not paying attention to something on the contralateral side of the world. That's probably the hardest symptom to pick up unless you're looking for it specifically. To go in a bit more detail than be fast, what we tend to do on assessment when people present to the emergency department is the NIHSS, so the National Institutes of Health Stroke Scale, and we score them on these particular features. So there's nothing fancy about this, and it all probably takes about 2-3 minutes to do. So you ask them a few questions like what month it is, how old they are. You ask them to open and close their eyes, make a fist. You ask them to look left and right. You check that they haven't got a visual field deficit just by putting up your fingers in both visual fields. Check for power in the face, the arms, the legs. Check if there's any incoordination and if there's any sensory loss. Sorry, I think the advert for whatever app was doing this has covered the last few bits, but the last bits are checking speech, both for aphasia, so mixing up words or unable to name things, as well as slurred speech, dysarthria, which you can see in posterior circulation strokes. And it's scored out of 42, and a mild stroke is typically less than 8, and a severe stroke is up to 25, 26, for example. So the diagnostic pathway for a stroke, I mean, ideally, this is all happening at a hyperacute stroke unit by people trained up to do this. But if you're seeing someone who has a suspected stroke, the important things really are confirming the time of onset, because that makes a big difference into whether they're eligible for thrombolytic therapy. So currently, we tend to do that in most people within 4.5 hours from the time of onset. But now, of course, we also have another procedure called thrombectomy, and for that the time criteria is a bit more relaxed, so it's worth just finding the time for onset and still trying to note it down even beyond that 4.5 hour time window for thrombolysis. In terms of the OBS and examination, so apart from the NIHSS, of course, it's worth seeing if they have atrial fibrillation, very common cause of stroke in the elderly. Checking their blood pressure, making sure they're not too hypertensive, because that should be treated. Checking glucose, drug history, recent bleeding, previous brain bleeding, and a lot of those factors in terms of drugs and bleeding, that's to make sure they have no contraindications to thrombolysis. Then, of course, they should have a CT brain scan, and that's because you want to find out if it's ischemic or hemorrhagic. I've mentioned that there's a few clinical symptoms that might be different in the two, but you can never know for sure, so everyone needs to have a CT brain scan to make sure you're not going to thrombolyze someone with a hemorrhagic stroke, which would be devastating. And then the pathways diverge after the CT scan. So if they have an infarct, sorry, there's a typo there. It's alteplase, so intravenous alteplase is given as a bolus and infusion, and they can be considered for clot retrieval, what we call mechanical thrombectomy. And the evidence for that has only really been there since about 2015. Controlling blood pressure is important. It's more important to control blood pressure in bleeds, and in bleeds we also reverse the effect of any anticoagulants or antiplatelets if there is any of those on board. But there's not much more we can do for bleeds other than supportive care. So that's all about stroke. Moving further down the pathway, still in the upper motor neuron territory, spinal cord compression, which is another neurosurgical emergency, really. So this can occur acutely due to trauma. Sometimes it can occur acutely due to tumor as well, so metastatic spinal cord compression, and the most common ones are mets from breast, lung, or prostate. Rarely it can happen acutely from disc prolapse, and the others, abscess could be is a rare cause of acute cord compression, and arthritis typically is going to be degenerative over months or years. And by that I mean cervical spondylosis. So symptoms of spinal cord compression. So I suppose the most specific one is the loss of bladder, bowel, or sexual function, which you don't tend to see so much with strokes, or with, well, you certainly don't really see it with Guillain-Barré or myasthenia gravis. So that's something to definitely ask people about. And of course, if there's any suspicion, then a PR exam is mandatory. Depending on the level, people will have paraparesis, tetraparesis usually, and if it's a very high spinal cord compression, then they may even have diaphragm paralysis. So as you may recall, C3, 4, and 5 keeps your diaphragm alive. And they may also variably have loss of sensation or sweating, which is to do with the autonomic damage. Of the signs on examination, upgoing planters tend to be the earliest abnormal sign after a spinal cord compression, but even that takes a few hours to develop. Tone and reflexes can be very variable, so don't rely on those to exclude spinal cord compression. It may take weeks before people develop spasticity and brisk reflexes, which is what you expect with upper motor neuron lesions. But yeah, same as a stroke actually, so you won't get those immediately. Patterns can help you as well. So although this is for sensory patterns, it's equally applicable to weakness as well. So anytime someone has bilateral weakness or sensory loss, always think about a spinal cord lesion first. If it's unilateral, it's a bit harder. You should be thinking about a stroke first, especially if the face is involved. But if the face is not involved, then it could be what we call a Brown-Séquard syndrome, so a hemisection of the cord, so a lesion just on one side of the spinal cord, if you imagine this is a cross-section causing that lesion there. Rarely, I don't think you need to worry about this. I mean, very unusual for syringomyelia to present acutely, but rarely you can get spinal cord syndromes that present in this sort of suspended fashion, by which I mean there's an abnormality up here, but it's all normal down there. Much more common is that you'll have a spinal cord lesion and everything below that level is going to be affected. Delving into the anatomy a bit more, you can divide things into dorsal columns and the anterior cord. And that's relevant because different sensory modalities are affected with those, but I won't talk more about that here. In terms of the pathway, if you're suspecting that, then of course you should try and organize an urgent MRI scan of the spine. Ideally, you should image everything above the level where you think the deficit is. So if both legs are weak, really you need to do the whole cord. If they're quadriplegic, so both arms and legs are involved, then it's just the cervical spine and the brain that you need to do. And of course, you need to refer to neurosurgery as soon as possible after the imaging's been done. Typically, if it's metastatic spinal cord compression, then dexamethasone can be useful. In all cases, we keep the patient flat, minimize movements, and then, of course, there's supportive management for anyone who's bedbound. So, you know, catheter, pain relief, prophylaxis for pressure ulcers and DVTs. So next. So these aren't sextuplets. This is one man, and it's 6 images taken a few seconds apart. And you can see what happens as he keeps looking up. Gradually, his left eyelid droops more and more. So it's a classic, well, non-video photo slides of fatigable ptosis on the left. What you can also see is actually that the eyes are pointing in different directions. And again, it's very common in myasthenia gravis, which is what this is, to have diplopia alongside the ptosis. There's probably a hint of wasting as well that you can sometimes see of the temporalis muscles on the side. So myasthenia gravis tends to affect young women, especially. So there's a bimodal distribution. So in the younger age group, it tends to be women, much less common to affect men. But then there's this other peak of incidence in middle age groups. And in that age, men and women are affected equally. The people who are at risk, they may have other autoimmune conditions. Sometimes you see people with rheumatoid arthritis or diabetes or Graves' disease who develop myasthenia. And this can present acutely because some people present with a myasthenic crisis or relapse as their initial presentation. And there's a wide range of things that can trigger this. So it can be infection, certain drugs, surgery and the anesthetics used, missing their medicine if they've already been diagnosed. But even something as simple as stress or changes in weather can trigger a relapse or a crisis in someone with myasthenia. The main patterns of weakness, so I mentioned the eyelids, ptosis, and diplopia. The other parts of the body that tend to be affected are the bulbar muscles. Sometimes the face is affected as well, but more commonly is the throat. So speech and swallowing are impaired. The respiratory system, of course, that makes it critical. And then some people have generalized myasthenia that affects the limbs. Yeah, so sorry, two subtypes of myasthenia are ocular myasthenia, which only affects the eyelids and eye movements, and generalized, which affects all of these 4 groups. And that's helpful diagnostically because those with ocular myasthenia need less treatment, as you'd expect. In terms of diagnosis, there's different ways to diagnose myasthenia. The best test is the antibody test for acetylcholine receptor antibodies. Some people, and that's present in about 80%. Some people will be negative for that, and of those, half of them will be positive for this other molecule called muscle-specific kinase. And these are all involved in the neuromuscular junction function, as you can imagine. These tests will take at least 2 weeks or so to come back, so it won't help you acutely. Another way of diagnosing it is electromyography, so EMG, and there's a specific thing they do called repetitive nerve stimulation. Think of it as a electrical equivalent of fatigability clinically. So they'll repeatedly stimulate a muscle and watch for the amplitude of the response getting less and less, which is exactly what you see when you ask them to do repeated actions with a muscle. It gets weaker and weaker after a certain number of times. Then there's some old-fashioned tests. So the tensilon test, which involves injecting something that will counteract the antibodies of the acetylcholine receptor. So it will release more acetylcholine, essentially. Excuse me. And then there's this other one called the ice pack test, which is sometimes helpful in those with ptosis. Essentially, you put an ice cube wrapped in a towel over the eye with the ptosis, and after about 2 minutes, you take it off and see if the ptosis improves. Not the most sensitive test, but it can sometimes be helpful if you're outside a hospital. Some of these other tests can be useful. So CK is useful to rule out other muscle diseases. IG electrophoresis is essentially useful before we give intravenous immunoglobulin. And serum TPMT assays only really with a view to think about whether they're safe to have immunosuppressants in the future, so particularly azathioprine. So moving on, this is the last of the syndrome. So we're working our way back up anatomically from the neuromuscular junction up to the peripheral nerve. So Guillain-Barré, I don't know if you've all seen it, but I'm sure you've all heard of it. The key points, some people may have a preceding infection 2 to 4 weeks beforehand. The classic example is of Campylobacter gastroenteritis, but it could be a respiratory infection as well. Often we don't find that history, so don't be put off by that. The first symptoms are usually ascending weakness from the feet, combined with a little bit of paresthesia, so some pins and needles maybe. It's quite usual to have mild sensory symptoms with Guillain-Barré, although it's predominantly a motor problem. And of course, the main worry is that it keeps ascending up to the lungs again. So it's another cause of neuromuscular weakness like myasthenia. On examination, absent reflexes are a very useful sign. Now, of course, there's a lot of variability with reflexes, and some people have poor reflexes, some people have very good reflexes, as I'm sure you know from medical school and practicing on your colleagues. I think it's more useful if you see reflexes that are present and then on serial testing after a few days you find they're absent. That's quite helpful in terms of showing that it's progressing. Also, it's helpful if a patient has some reflexes, such as in the upper limbs, but they don't have their knee jerks and ankle jerks, because that suggests it's pathological. You know, as if people are generally areflexic, they tend to be areflexic everywhere if it's a constitutional thing. So it's not quite as simple as that, because there are rarer types of Guillain-Barré syndrome, which can affect different distributions, including, for example, just the arms and the throat. Or even, well, Miller-Fisher, you may know about, that's ataxia and ophthalmoplegia tend to be the sort of hallmark features of that. Or even brainstem encephalitis, so something you wouldn't expect from a syndrome that affects the peripheral nervous system. But we know little about how it does this, but these are some of the other forms. Thankfully, the brainstem encephalitis is quite rare. So the diagnostic pathway, so obviously it's made as a clinical diagnosis. It's often useful to do an MRI scan of the spine to make sure there's no spinal pathology. And then the two key tests, a nerve conduction study and EMG, electromyography again, but this may be normal in the first week. Typically it's only positive or unequivocally positive after 2 or 3 weeks. So again, it doesn't help you initially when someone presents acutely. A lumbar puncture can often be useful, and you're looking for this finding of raised protein, but that might be normal early on. So there's no good diagnostic tests early on. In relation to a lumbar puncture, you may have heard about this thing called albuminocytologic dissociation, and that's just a very fancy way of saying the protein is raised, but the white cells are normal. In other causes of inflammation in the spinal cord or the brain, typically one would see protein being raised and the number of white cells being raised, for example, in encephalitis or meningitis. So the main point is with myasthenia gravis and Guillain-Barré syndrome, two of the most dangerous causes of neuromuscular respiratory failure, you won't have a definite diagnosis, but that doesn't matter in terms of what we need to do acutely. So the emphasis in both cases is to keep someone breathing. And the best diagnostic test in terms of seeing how their respiratory function is the forced vital capacity. And a little bit of an aside here, forced vital capacity is measured only using one of these instruments, although they look quite similar to each other, and it's this one on the right, so a spirometer, not the peak flow meter. And even senior colleagues can make those mistakes. So this is someone not long ago, seeing someone, one of my patients who had suspected Guillain-Barré syndrome or the chronic form Guillain-Barré, and no spirometer was available, so they just did a peak flow instead. Is that useful? Not at all, is a short answer to that. Peak flow is very different, and it's looking at the maximal flow rate of how fast you can blow air out of your lungs. So it's all dependent on the airways. So it's obviously useful in asthma and COPD, but that's it. The how far the counter moves in the peak flow meter is just in relation to the maximum flow rate, which is a consequence of how dilated your airways are. What we're interested in with the forced vital capacity is really how deep a breath they can take. So how much they can inspire. And that's directly proportional to how weak their diaphragm is. So if your diaphragm's not working well, you're not going to be able to take a deep breath in. And obviously we can't measure how much air they're taking in, so we measure it on the way out. So that's why we ask them to breathe out as much as possible. And here I'm not actually interested in how fast they blow it out. You just want them to empty their lungs of all the air. So vital capacity, I don't think this helps explain it in any more clearly than I've just done. So forced vital capacity is just a measure of the capacity in the lung. And that's what we're interested in. Typically, we say measure it 4 times daily, especially acutely, because we don't know which way these patients are going, whether they're deteriorating, stable, or actually improving. Surrogates for that, so you can ask a patient to count, and they should be able to count to at least 20 in a single breath, otherwise you'd be a bit worried. When you're measuring the forced vital capacity, one caveat is that make sure there's a good seal with their lips around the device. Often people with myasthenia and Guillain-Barré may have facial weakness, so they can't get a good seal, and that means air is escaping from the sides, so you're underestimating their vital capacity. And you should really alert intensive care if they have a forced vital capacity of less than 20 mils per kilogram, or a ballpark figure is about 1.5 liters. But of course, that's just one of the indications. I mean, you should take it all holistically, and if someone's rapidly worsening, even if they're above that 1.5 liter threshold, then you should always err on the side of caution. For reference, normal vital capacity is about 60 mils per kilogram, or about 4 liters. And then treatments that would be initiated, but this is really not as urgent. In intravenous immunoglobulin, plasma exchange, steroids are only for myasthenia, by the way. These treatments take days or even a week to start having an effect, so they're not going to help. So I would emphasize that you should be less concerned about those and more concerned about the respiratory aspect, because essentially you just need to support the lungs if there's any danger to them while the treatments take effect. And just, I can't remember who this quote is from, but yeah, so I haven't attributed it, but yeah, it's something in neurological circles. So FVC tells you what to do in myasthenia or Guillain-Barré. ABG tells you what you should have done. So ABG is a late marker for these conditions. When the PO2 drops, it's a bit late to act then. Lastly, just 2-3 minutes on COVID-19 and neurology. Of course, that's the reason for these talks, and so it'd be remiss of me not to talk about it at all. So COVID-19, I mean, there's a couple of neurological aspects that have been mentioned in the news. One is about loss of smell, and ENT surgeons have noticed this worldwide quite early on in the pandemic. Lots of coronaviruses can cause anosmia, and it's a very common cause of anosmia, so post-viral loss of smell is seen commonly with flu viruses or cold viruses. Interestingly, the statistic from South Korea, where they did a lot of testing in people with mild symptoms, found that almost a third had evidence of loss of sense of smell. So it's probably an under-recognized symptom. No one's really sure, though, if that means the neurons are affected themselves or if it's just from local factors because of the nasal obstruction or inflammation. So I think the jury's out on that. There's very well, active research area at the moment. Confusion, again, it's not really clear what causes the confusion, but it was found in China, in Wuhan, I think, in one of the hospitals that published data from their severe cases. They found that about 15% had confusion with severe COVID-19. And then looking at other diseases that they had in the nervous system, so about 5 people, and there's a study of, I think, just over 100 people, 5 people had strokes. And then there's a couple of isolated case reports from elsewhere in the world of meningitis or encephalitis. One of those studies actually found the virus responsible for COVID-19 in the CSF. I'm not really sure what to make of much of that. I think the confusion is likely to be due to the fact that many of these patients are of the older age population. And those of you who tuned in will know that from yesterday's talk that delirium is much more common in those patients. But of course, these people with severe infection have multi-organ failure and other complications as well, which could easily cause confusion. So it's not clear that the virus itself is causing confusion directly, essentially what we'd call an encephalitis, a direct infection of the brain. Even if it is, it seems to be very rare, thankfully. And a couple of other things. I mean, I suppose if we go into the preclinical setting, as I said, other coronaviruses, as well as the current one, have been found in CSF. And even in those, no one's quite sure if they cause pathology. So these are the more common sort of flu viruses. The previous most similar viruses to the one causing COVID-19, SARS-CoV-2. So these would be SARS-CoV-1 and possibly MERS-CoV. These have occasionally, quite rarely, caused CNS infection. So there are case reports of encephalitis. ADEM, which is acute disseminated encephalomyelitis, essentially like a one-off attack of MS, I suppose is one way of thinking about that, as well as Guillain-Barré syndrome. But again, these numbers are quite low. But there is evidence that the other viruses in the past related to SARS-CoV-2 have affected the nervous system. So we may see that in some people. There are some hypotheses, but again, none of these are proven. So some people have suggested that the anosmia suggests the olfactory neurons are affected. And from there, the brainstem respiratory centers could be involved. And that might be part of the reason people have such bad respiratory failure. I'm not so convinced by that. There's also, as you know, a lot of debate about ACE2 receptors. One group have found that ACE2 receptors, or actually it's been known for some time that ACE2 receptors are present in various cells in the central nervous system. So that could be a way for the virus to get into the brain. But as I said, generally, I think everyone's quite confident that it's not a common consequence of COVID-19 infection. And I'll stop there. So thank you very much.
Well, thank you for that very comprehensive and practical talk. This can often be very complex topics, so it was really great to hear your expertise in laying it all clearly out for us. Your slides on COVID at the end were very interesting. Thank you for taking the time to include these. There have been quite a few Q&As building up. Can we run a few of these by you?
Sure.
So at the beginning, there were a few questions, particularly on clotting studies and lumbar puncture. Would there be any situations where you would wait for the clotting studies to come back before doing the LP?
Only if they're on drugs that would affect it. I mean, it comes back to clotting studies in any situation, I guess, like before surgery. I mean, it depends on your threshold for suspicion of deranged clotting. But unless they're on medicines or they say they have a history of easy bruising or abnormal bleeding, no, I wouldn't send off clotting studies. I certainly don't think you should wait for them routinely.
Sure. And if we have a patient that's on warfarin with a raised INR, say over 1.4, would you give vitamin K before doing the LP?
I think ideally one should do that, to do the LP as soon as possible. The problem is the later you do it, the less likely you are to find the organism responsible. And of course, in most cases, you'll cover them with the antibiotics empirically, but it's always best to be sure if possible.
Yeah. And we had some questions as well about thrombectomies. How long would the window of opportunity be after the onset of symptoms?
So that's more complicated, and usually that relies on more advanced imaging. So many of these stroke centers will do CT angiograms, which are specifically looking at the blood vessels, and they want to look for evidence of the clot. And then there's more advanced scans still, which rely on reconstructions of the brain, such as a CT perfusion scan, which estimates what portion of the brain is dead beyond repair, essentially, and what portion of the brain could be salvaged if the clot was removed. So based on those factors, as well as the clinical symptoms and the time of onset, thrombectomy can be offered as much as 24 hours after the initial onset of the stroke. So there could be a long time window, but only in specially selected cases.
Another reason to get the stroke team involved early to help set up the complex investigations that need to happen.
Yeah, definitely. I mean, I think if you see a suspected stroke and you're not in a hyperacute stroke unit, you should always alert them, because they may want the patient to be diverted to them as soon as possible.
Mm-hmm. And when we're waiting for the stroke team to arrive, what sort of imaging would you do in the first instance, and what would you be looking for when the images come through?
So I wouldn't expect anyone at the junior level in acute medicine to be looking for anything. It has to be the radiology team on call that do it, or the stroke team themselves. But essentially, you'll be ordering a plain CT scan of the brain. A chest X-ray can be useful as a baseline, but sometimes it's better to do that after an NG tube has been inserted if the patient has difficulty swallowing. But really, it's a plain CT scan of the brain. It's worth alerting the A&E CT radiographer as soon as the patient comes in and you think it's a likely stroke, just so they can free up the scanner so there's no delay.
And then a final question for now. We often find endoscopy as being a very difficult part of the clinical examination. Do you have any tips for how we can improve our chance of visualizing the optic disc?
Yeah, I think that's hard. And so I teach for MRCP as well. And again, everyone always says the same thing. It comes down to practice. Just like how, everyone's very comfortable auscultating for heart sounds. It's all from practice. There are a couple of tips. I mean, I'd say with the ophthalmoscope, go in from a 30-degree angle laterally, so to the side of the patient, and then go in horizontally as well in the midline, and you should be coming right onto the optic disc as you get close. Many people don't get close enough, so it's, you have to get very close to the pupil with the ophthalmoscope to get a good view, and then and then just keep still and have a look. And it will be hard in the elderly because they'll have small pupils, and many of us can't get good views unless we dilate the pupils. So don't be put off by that, but practice as much as you can.